pressure is on to stay on time.
That's right.
I've got my timer here too.
Okay,
I'm Ross Martin with CRISP, and do I do something to clickbait this? Is somebody else controlling it? Oh, you guys are
from afar.
Okay, excellent. So it's coming up. I'm going to just wait for that to happen. I'm going to hit my start. Ross Martin from CRISP. So we are the Health Information Exchange, the state designated entity for Maryland. We also service DC. We are also the technology infrastructure for West Virginia. I've got more slides in here than I'm going to cover really, but it's for your edification. Also to give you a teaser for Tuesday, I'll be presenting with Walter Sajansky and Julia Adler-Bilstein on some other population health stuff. And if you want to know more about CRISP, you can go to that session on Tuesday. If I have one thing to say to you, it's the William Gibson quote. He was famous for Neuromancer, interesting cyberpunk novel. Future is here. It's just not evenly distributed. My apologies for those where English is not your first language. I'm not going to slow down because I've got a lot of things to say. But this is really what is true at a CRISP level, but also as you're going to hear as you've heard from Marianne about the care quality at a national level as well. We are making a lot of progress. We're finding lots of places with lots of data, but we've got a long way to go. As I mentioned, we are serving Maryland, District of Columbia, and West Virginia. If there's one theme that happens at CRISP, it's this first guiding principle of being incremental. I think it's tattooed onto my CEO's chest, except it's only increm because he's incremental about it. If you look at what we do, we're the designated health information exchange for Maryland. That gives us regulatory oversight from the state to do a lot of the things. We're kind of the default place that funding goes to do things that are where we're going to do things cooperatively and build things as a public utility, if you will. We're not for profit, 501c3. We are not a state entity, but we are regulated by the state. We're the de facto for District of Columbia. We share data with Delaware through the Delaware Health Information Network. So for example, if a Delaware resident shows up in Maryland and shows up at a hospital, and we see that Delaware address, we send them a note about that, and they do the same thing for Maryland residents showing up in the 6 hospitals in Delaware. We do the same thing for northern hospitals in the Inova system, and about 20-some hospitals in northern Virginia. And then last summer, we became the technology infrastructure for West Virginia. They kept their governance there. They're actually moving from a state entity into a not-for-profit status this year, but we are the technical infrastructure for them now, and they basically piggyback on the services and products that we offer to DC and West Virginia. We are governed by our people, by the people who use our services. There's kind of the owners, if you will, are the 3 main health systems in Maryland, University of Maryland, Johns Hopkins, MedStar, and Erickson Living, who was the retirement community. John Erickson gave the seed money initially for this because he was tired of his patients showing up, or his residents, his residents being sent to the hospital with their medical information literally tied to their chests, and then coming back a few days later with not knowing what they're on, what happened to them, what needs to happen to them, and he was very frustrated with this. He set this meeting up, and our governance is very complex. It's a lot of oversight to say, what can we do next? And part of the challenge is everybody wants us to do lots and lots of things, so we're always trying to incrementally show value in that. I just want to mention we are an opt-out state. That has a big implication on how you do certain things, especially when you're talking about social determinants of health. So under HIPAA, we're covered under HIPAA and some other things, but essentially a patient has the opportunity to opt out of CRISP by default. So they're in the network unless you actively do something. Other places do it the other way around, and the disadvantage there is you have to build up a critical mass of data before you can get anything going. Things like social determinants don't really follow under HIPAA in the natural way, which is kind of what the primary governance for us. And so we actually have to do things like get people to opt in if they want to do things like care coordination, care management, or send us their information about things like Meals on Wheels, which isn't considered a medical service, right? Even though, as we heard from Dr. Tierney, these are the things that really make a difference. If you don't have housing, if you don't have transportation, those are what you need. So we have to really figure out how we're doing that. I think Maryland is one of the most successful HIs in the country, not because of any magic that we have in terms of the smart people or the things, but really because of the Maryland waiver that happened back in the 70s, where we get the hospitals rates are set by the state for all payers. And this has a real big impact on their willingness to share data with one another because they're all kind of in the same boat. And now we actually regulate their revenues for the year. They know how much money they're going to make every year, and that has an impact on what they're doing. I'm not going to go more into that, but just trust me, that's a big, that changes the conversation when you're all trying, when you all have this at stake. Instead of treating information like intellectual property that you want to protect at all costs, you're saying, I need to get this to you as fast as possible so that I can impact my bottom line. Just in terms of scale, it's important to know. I want you to just point your notice to the ADT number. That's admissions, discharges, and transfers. We get about 17 million of those notices a month. These are the simple things. If I show up in the emergency department or I get admitted to the hospital, Chris gets an ADT message immediately from that. But for every admission, we might get 20 or 30 of these messages when you get moved to the radiology system, when you go to the ICU, when you get out of the ICU, we get a message for all of those things. And most people just want the admission and they want the discharge. That's what they want to know about. And the way we move these things around is you send us a list of patients. You say, these are my patients. These are the people I'm seeing right now. We have different rules about how long you're allowed to get messages about them based on if you're a primary care provider, for example, or an ambulatory provider, you get 18 months of information from us. If you just seen them in the emergency room or got admitted to the hospital, that's acute care. You don't have an ongoing relationship with that patient. So you're allowed to see that for about 60 days. So we have different rules about that. But those messages translate into about 2.5 million messages per month that are going out to somebody who is subscribed to that patient. And this is how social determinants can be delivered as well. So you can just see our numbers going up. We're getting more and more use. If you want to look at how many people, again, the futures here is just not evenly distributed. All these different things represent types of messages we get or types of data we get from different places. And those, you'll see, you can look at that list on our website. The messages come in by, through that process I just described. You give us a panel. When the person shows up, we get the ADT message. We send that out as a notification, and that turns into a notice we call ENS prompt. And these are the kinds of places we can send things like information about your social determinants and other population health things. Once you get that message, you can look up in our query portal and see lots and lots of stuff about those people, encounters, notices, and things like this. And this is our query portal, it's called. And I want to turn your attention to a couple of important things because this is right now how we're delivering things about things like care coordination and does somebody have a special thing, and that's in the care alert section. If I have one magic thing I think CRISP has done that to me could really change what we're doing, it's the concept of a care alert. And this is, if you think about SOAP notes from the when we transition from just writing long narratives to actually structured medical documents in the subjective objective assessment plan, a care alert, thank you. A care alert is really that kind of thing, and this is sort of my last big point. This is where we're putting things like, and I want to get to the next one that I actually took one out of the query portal, and I know you can't see this, but the first one is, this patient is available for care management services. Please contact blank. And this is what an ED doc can see when that person shows up. And then there are the much more specific care alert information from that. And the point of the care alert is to distill down the sea of data that we're in, because we're moving out of this problem. If I don't have enough information, now I've got so much stuff flowing at me as a provider, I don't know how to distill it all. And this is what we really need to get at. Here are just some other examples of care alerts. Again, they can include much more information. This is the transport mechanism we have for doing this. That's my 9-minute warning. And then just the last point about how we're doing this from a care management software strategy. We've kind of employed two different approaches. One is to offer a care management platform. It was called MirthCare. It actually kind of didn't go so well. We're ripping that out and we're doing another a replacement for it. But the other one was to send these things back. Instead of sending them as or making somebody go to our portal, we are sending people to, or we are sending data to people via application programming interface, APIs, web services, so that they can get these specific things. And that's kind of our strategy for incorporating social information about their medical needs and the availability of those services. This is the last point of, if you look at what we've been trying to do in terms of goals of this, our goal was to take the 20,000 highest Medicare beneficiaries, who don't have a known disposition that they pass away. We want half of those to be having information available to the provider where they've identified a care coordinator and a PCP. And we've been approaching that over time. A similar one is about getting those same 20,000 high needs beneficiaries getting a care alert or equivalent. And again, we went from 0 to a lot in the last 12 months, and we're trying to move that forward even more. This is, I think, the vehicle in a very practical. I wanted to show you just practical, tactical ways we're trying to get this stuff to you, and I'm done.
Thank you. And last of the panel